And you are live.
Good afternoon and welcome back to the third session, which will focus on cancer risk assessment for colorectal cancer, family history of colorectal cancer, genetic testing, cascade genetic testing, and how we can improve all of these aspects of care and how to facilitate both patients getting the appropriate colonoscopies that they need and the appropriate cancer risk assessment with genetic testing. So we have 5 fabulous speakers lined up. After first 2 speakers, we'll have a Q&A session, and then we'll have another Q&A session after the last 3 speakers. So the first 2 speakers will be David Greenwald and Bryson Katona, and we're so happy to have them here today. Dr. Greenwald will focus on colorectal cancer population screening and adherence to recommendations. And Dr. Katona will focus on surveillance in high-risk patients with advanced adenomas or genetic susceptibility. And we really look forward to both of these topics. I believe Dr. Greenwald may not be able to join us, but if he is, then we'll obviously look forward to having him as well. Thank you.
Good afternoon, everyone. I want to congratulate the organizers of the 7th Annual Colorectal Cancer Summit, and particularly thank Cindy Barassi for another great meeting, and thank everyone for inviting me. I come to you this year from Mount Sinai Hospital and have the honor this year to be president of the American College of Gastroenterology. My task today is to kick off this section by addressing screening guidelines for colorectal cancer, discussing what are the guidelines and how we are doing in terms of adherence. I'd also like to say a few words about how the COVID-19 pandemic has impacted all of this. So the US effort to screen for colorectal cancer in recent times has been a multifaceted campaign. A noteworthy goal was put forth in 2012 by the National Colorectal Cancer Roundtable to aim for 80% screening by 2018. Well, with 2018 having now come and gone, that campaign is now called 80% in every community. As I've reminded many, a community can be any way you define it. And so 80% is a very achievable goal. 80% can be those people you know, those people in your church, those people in your physical community. 80% is everywhere if you look for it. The bottom line on colorectal cancer screening, it is typified by this blue star and the notion that colorectal cancer is largely preventable. And if not prevented early, it's treatable, and therefore it's beatable. So let's start with how we are doing and then circle back to the guidelines. There really has been great progress in colorectal cancer screening rates in the United States. Between 2000 and 2015, colorectal cancer screening is depicted in the lowest of the blue lines you see here, with a steady rise over this 15-year period, getting much closer now to uptake for mammography and Pap screening. As you might expect, there are differences regionally in screening rates in the United States. And this depicts the United States in 2016, some with screening rates depicted in blue or dark blue, over 70 and 75%, and others shown in red, under 60%. But overall colorectal cancer screening rates in the United States have increased from 37% in 2000 to over 67% in 2016, and that trend continued in the latest data in 2018. Not quite the 80% that the NCCRT recommended in 2012, but a remarkable achievement nonetheless. And as I said, 80% is achievable in communities all over this nation. So let's circle back to the guidelines, as I said, and what do the various guidelines actually tell us? One of the most highly cited guidelines is the US Preventative Services Task Force, guidelines last published in 2016, which listed a menu of options, encouraged shared decision-making, and lamented that screening was underutilized. Of note, this guidance has been updated and was sent out for public comment in late 2020, with the final version expected in mid-2021. The US Preventative Services Task Force guideline divides options among those that are stool-based, including guaiac FOBT, FIT, and FIT-DNA, and those that are characterized as direct visualization techniques, including colonoscopy, CT colonography, flexible sigmoidoscopy, and a combination of FlexSig and FIT. It specifies frequency as well. Of note, this guideline is the one that most insurance carriers follow. And as I said, an update has been sent out for public comment, and we expect the final version in coming months. Of note, the United States Preventative Services Task Force in 2016 recommended screening between ages 50 to 75. Recommendation, but was less strong about those between ages 76 to 85. For those between age 76 and 85, it recommended individualization and said that the most benefit would accrue to those who had not previously been screened. Here are the United States Multi-Society Task Force recommendations from 2017. These are the 3 US-based GI societies. Note a different scheme here with Tier 1 tests, colonoscopy every 10 years, and annual FIT testing, along with Tier 2 tests, which include CT colonography, FIT DNA, and flexible sigmoidoscopy. The US Multi-Society Task Force recommended screening at age 50, although recommended screening at age 45 in African Americans, more on that later. The ACG had made the same recommendation about screening African Americans starting at age 45 years ago. There was also guidance in the US Multi-Society Task Force recommendations to consider stopping at age 75 or whenever life expectancy was less than 10 years. A landmark change occurred in 2018 with the American Cancer Society screening guidelines. These recommended screening for average risk individuals to start at age 45 using either a high sensitivity stool-based test or a structural exam, noting patient preferences and test availability as important factors. The idea of shared decision-making about that choice was emphasized. Also, the clear need for follow-up of positive tests, positive results on non-colonoscopy screening tests with timely colonoscopy was reinforced, and this remains a key issue. And here are the now published ACG guidelines from 2021, published in March of this year. The American College of Gastroenterology recommends colorectal cancer screening for those 45 and above, with somewhat stronger evidence cited for those above 50. The primary modalities are colonoscopy and FIT, and alternatives for those unable or unwilling to undergo colonoscopy are provided. Note the new approach here in the ACG guidelines, describing choices as one-step or two-step screening, again emphasizing a continuum of screening for stool-based tests that are positive. Intervals outlined remain similar to those in previous guidelines. And so to enhance the how are we doing factors, there are many ways to break down barriers, and breaking down barriers remain key. Here is one in New York at Mount Sinai, the roll-in colon, which helps to demystify colorectal disease and colonoscopy. And pictured here are some of my Mount Sinai colleagues. So let me then turn to the effect of COVID-19, the pandemic, focusing on colonoscopy and colorectal cancer screening. Indeed, many studies and data sets showed a dramatic decline in endoscopic volume throughout the pandemic, with a very sharp drop at the outset. Indeed, an international survey study of 250 centers worldwide showed an 83% reduction in endoscopic volume. Initially, much of that drop in volume was due to fear, completely reasonable and well-founded fear, and a lack of appropriate PPE. A similar study in the United Kingdom found procedure volume to be 12% of pre-COVID volume, or a drop of 88%. This drop in volume had and still has a profound effect. Here are source data demonstrating that drop from New York on the left, where you see pre-COVID in the light bars and post-COVID in the black bars. Focus your attention on colonoscopy in graph A, and you see a marked drop in colonoscopy volume post-COVID. The graph on the right is from the United Kingdom, with all procedures in blue, notably at a steady state on the top through March of 2020, and then essentially a free fall with only a 20% recovery noted 2 months later. And we finally have current data from a preprint in a study that was published in Gastroenterology in March 2021 on the impact of COVID-19 on GI procedures and cancers. You see on the graphs on the left a marked drop in ambulatory visits, inpatient visits, and emergency department visits between 2019, which is shown in blue, and 2020, which is depicted in orange. The bottom of these two graphs shows a marked drop in procedures as well. Again, focus on upper endoscopy and colonoscopy on the left, with 2019 in blue and 2020 in orange, and you see a dramatic decline in procedure volume. I will come back to this study to address cancer in a few moments. So let's turn to colorectal cancer screening. The chart on the left is from the National Colorectal Cancer Roundtable and the American Cancer Society, and demonstrates a greater than 90% drop in colon cancer screening colonoscopies in the United States in early 2020. They estimated almost 19,000 missed or delayed diagnoses of colorectal cancer from early March through early June 2020. And the impact will be 4,500 or more excess deaths from colorectal cancer over the next decade. I remind you that this represents only a few months in 2020, so these numbers are likely to be significantly higher. So back to that preprint I showed before, but now adding cancer in the graph on the right. And notice colorectal cancer all the way on the right over here. New diagnoses of colorectal cancer were down sharply from March to July and still down from July to November in 2020. Again, blue is 2019, orange is 2020. The cancers haven't gone away, they just aren't being diagnosed. And the result presumably will be later stage tumors with worse prognoses to be diagnosed in the future. You can see the same thing for other GI cancers in the rest of this graph. We must also note the disparities of care and outcomes for COVID-19 amongst various communities, now very well recognized. In relation to colorectal cancer screening, this terrific article published in GI Endoscopy in October of 2020 outlines potential solutions to impacted areas where COVID-19, where colorectal cancer screening was made worse by COVID-19, and I recommend it to you highly. And so here is the American Cancer Society marketing materials and press release that highlight three major points about marketing a successful return. And they are: don't postpone regular care, resume regular health care, and there is a cost, and I'm not talking about dollars, but I'm talking about outcomes in healthcare quality to missing screening activity. Bottom line, regular cancer screening and colorectal cancer screening is still important. Raising public awareness is key. Getting out the message is key. So here's the American Cancer Society getting the word out that screening at age 45 with a very successful Ride or Stride campaign. On the left, you see a t-shirt from the newly formed Association of Black Gastroenterologists and Hepatologists, simply stating, ask me about colorectal cancer screening. And you, just like my colleague in Chicago, Andrew Albert, could dye your facial hair blue, for example, or your hair blue, or anything you want blue to promote colorectal cancer awareness. I love this. So the impact of COVID-19 and the pandemic on colonoscopy and on colorectal cancer screening has been not unexpectedly quite profound. I think many of the changes will likely persist for some time to come. We've clearly found out that we are resilient and creative, and we'll continue to rely on our connections, our collaborations, and our camaraderie to continue to work to increase rates of colorectal cancer screening despite all the barriers that have been thrown in our way. And in so doing, continue to reduce incidence and mortality from colorectal cancer. And so with that, I thank you so much for allowing me to participate today in this most important summit.
Hello, everyone. My name is Bryson Katona, and I'm the director of the Gastrointestinal Cancer Genetics Program at the University of Pennsylvania. I'd like to take this opportunity to thank the organizers for the opportunity to come and give this talk about a topic that I think is incredibly important. So here are my disclosures, none of which are pertinent to the talk that I will give today. So today we'll be talking about colonic surveillance in high-risk young patients. And first, we'll go through a little bit of epidemiology about early onset colon cancer and early onset colonic adenomas, then talk about colonic surveillance in young patients with genetic risk, followed by colonic surveillance in young patients with colonic adenomas. Then finally, we'll touch on some of the effects of COVID-19 on colonic surveillance in young patients. So let's first review a little bit of epidemiology. So we all know that colorectal cancer incidence and mortality has been decreasing over the last several decades. But of concern, of course, is the group between ages 20 to 49, where we've seen an increase in colorectal cancer incidence over the last several decades. Much of this increase in incidence has been driven by an increase in rectal cancer, as you can see over here on the left. And while rectal cancer in 2010, of all rectal cancers, 9% were in individuals under age 50. It's predicted that by 2030, that 22% of all rectal cancers will be in individuals under age 50. How about colonic adenomas, and how frequently are those found in young patients? Well, looking at an older study back from 2005 from the Dutch Hereditary Colon Cancer Registry of young patients who had undergone colonoscopy and then later been found to have negative genetic testing, you can see that colonic adenomas were found in about 3 to 4% of these young patients. However, more recent studies have shown a higher rate of colonic adenomas. And so this was a study looking at 166 patients under age 40 who underwent colonoscopy. And in this study, they found that 21% of these individuals had colonic adenomas. There was a very nice meta-analysis that was published just earlier this year by Samir Gupta and his colleagues that looked at all of the different studies that have looked at prevalence of colonic adenomas in individuals who are under age 50. And what they found was that an overall prevalence of about 9%. This is probably more common than many of us expected, and certainly indicates that we are finding these adenomas in young people at a fairly robust rate. The only factor that they found that was associated with increasing risk was actually advancing age. So the older the age, the more likely that a colonic adenoma would be identified. So why are we finding these early onset colonic adenomas? Well, first of all, we're doing colonoscopy more frequently in younger individuals, especially for investigation of symptoms. Second, we have better technology, and especially with the use of high definition white light endoscopy. And then third, there's been an increasing push for endoscopists to be more aware of small adenomas, especially given the focus on the adenoma detection rate. And so I think because of all of these factors, we're certainly going to be finding these adenomas more frequently in young individuals. So let's move on to colonic surveillance in young patients with genetic risk. So when we think about genetic risk for colon cancer and colon polyps, we can group these syndromes into some historically well-established ones, such as FAP and Lynch syndrome and MUTYH-associated polyposis, as well as the hamartomatous polyposis syndromes. There are also newer syndromes, such as axin 2-associated polyposis and hereditary mixed polyposis syndrome. And going through the surveillance for each of these syndromes individually is beyond the scope of this talk. However, there are many guidelines out there, such as those from the NCCN, that do address all of these specific syndrome-specific surveillance intervals in more detail. But the overall theme of all of these guidelines is that for these hereditary risk syndromes, colonic surveillance usually will start earlier and will be done more frequently than the average risk population. I think it's also important to note that in these high-risk conditions that oftentimes colonic surveillance has to be continued more aggressively, regardless of whether or not there are findings on surveillance. So for example, a young patient with Lynch syndrome, even though he or she has had several normal colonoscopies, doesn't mean that they can necessarily relax the future surveillance interval. What I'd really like to spend the majority of the time on is talking about colonic surveillance in young patients with colonic adenomas. And I'm going to give two cases just to get people thinking about this topic in a little bit more detail. So the first case is a 25-year-old female with no past medical history who came in with a change in bowel habits. She has no personal or no concerning family history and no prior endoscopic procedures. A colonoscopy is performed and she has a very small sub-centimeter sessile serrated lesion, or an SSA. So in this case, what would you do? So we can't do this poll in person since we're all virtual this year. However, assuming that she has no hereditary syndrome, when would you consider repeating this patient's colonoscopy? I bet that if we were doing this in person, we would actually see a large variation in what people would actually recommend doing for this young woman. And how about this case, similar case, 23-year-old with no pertinent past medical history who developed rectal bleeding. Again, no concerning family history and no prior endoscopic procedures. She gets a colonoscopy, and there's a very large tubular adenoma with high-grade dysplasia that's detected. Now, how about in this case, what would you do? When would you repeat her next colonoscopy, assuming she did not have a hereditary syndrome? I would bet that most people would probably do it at a shorter interval than the first patient, but I bet that for this patient as well, if we were doing this in real time, we would see multiple different answers for what the appropriate interval should be. So let's talk about colonic surveillance in young patients with adenomas. Looking back 15 years, over the last 15 years, our management of these individuals has certainly changed. So 15 years ago, this was an algorithm that was published by Satma Singhal and Elena Stoffel, looking at management of individuals with young onset adenomas. And back then it was thought that these young onset adenomas may actually have an increasing future cancer risk. And so these patients were managed much more aggressively. So for individuals with no concerning family history who had 1 to 2 small adenomas, it was recommended that they actually have yearly colonoscopy for at least several years. However, as we've collected more data on these patients over time, I think we've come to realize that the future risk related to these young onset adenomas is actually lower than expected. So this was a multi-center study that was done out of Korea, looking at 14 different centers and thousands of endoscopies. What they did was they looked at individuals who had colonoscopies prior to age 50, and then those who had colonoscopies between age 50 to 54. And what they found was that for individuals who had a high-risk adenoma found on their initial colonoscopy, at their 3-year follow-up, there was no significant difference in risk between the two cohorts. Likewise, they looked at individuals who had a low-risk adenoma on their initial colonoscopy, and they found that between the two groups, there was actually no difference in advanced neoplasia on subsequent colonoscopy. And in fact, they found that younger individuals actually had a lower rate of non-advanced neoplasia on their subsequent colonoscopy. Similar results were identified by Carol Burke and her group at Cleveland Clinic, which looked at 128 patients who had a colonoscopy performed under age 50 with at least 1 polyp removed. And what they found was that compared to older individuals, they found similar rates of advanced neoplasia between the younger patients and the older patients. And they actually found that on follow-up, that the younger patients had lower rates of high-risk polyps compared to the older patients. And if you look at this risk of advanced neoplasia over time, what you can see is that regardless of whether the patient is under 50 or older 50, that these risks of advanced neoplasia are fairly similar over time. This was also looked at in the recent meta-analysis by Samir Gupta and his group, looking at several different studies that have focused on the prevalence of metachronous neoplasia after identification of a young onset adenoma. And they found that the overall prevalence of metachronous neoplasia following a young onset adenoma diagnosis was about 6%. So taking all of this data together, what does it tell us? Well, it really tells us that for someone that has a early onset colonic adenoma diagnosed, that the metachronous neoplasia risk after this young onset adenoma is actually fairly similar to older individuals. And of course, this is in the absence of a high-risk genetic syndrome. And therefore, for young individuals who have colonic adenomas discovered, really we should be using standard surveillance guidelines. So how are we doing with our recommendations for surveillance in these young individuals? So this was a study that was published a couple years ago that looked at endoscopists' recommended surveillance intervals after discovery of a young onset adenoma. And they looked at individuals who had had a high-risk adenoma detected as well as individuals who had a low-risk adenoma detected. What they found was that almost all patients were told to repeat their colonoscopy within 5 years. And if guidelines were actually not followed with this surveillance recommendation, they found that patients were actually typically brought back sooner than guidelines would have recommended, which probably is not too surprising. Of most concern, though, is that only about 25% of these patients were actually compliant with their surveillance recommendations, indicating that we have work to do in this area. So when you think about colonic surveillance in young patients with colonic adenomas, I think the future colonoscopy interval really should be based on the polyp pathology. And really, we should be using the surveillance guidelines that are in place for older individuals in the absence of a known hereditary genetic syndrome. If future colonoscopies are normal in these individuals, though, I still think that we probably should be repeating colonoscopy at least every 5 years indefinitely, at least until we get more long-term data on this population. There are certainly exceptions to these rules. So if the initial polyp that was resected may potentially have had unclear resection margins, or maybe the patient had a suboptimal prep, or maybe the initial colonoscopy was done more to investigate symptoms and was more a diagnostic colonoscopy, say for diarrhea or some other symptoms, and it may really have not have had the great attention that's needed for a high quality screening exam. In any of these cases, it would be reasonable to repeat the colonic surveillance at a shorter interval. So lastly, I'm going to turn to some of the effects of COVID-19 on colonic surveillance in young patients. And we know that colonic COVID-19 has had remarkable effects on cancer screening, not just regarding colonoscopy, but across multiple different types of cancer screening. The reductions in colonoscopy during the height of the COVID-19 pandemic in the spring of 2020 were remarkable, with up to 80% reductions in colonoscopy use for colon cancer screening. That subsequently led to a reduction in colon cancer diagnoses during this time as well. Some modeling studies looking at the effects of these delays have predicted that delays of greater than 6 months would lead to a significantly increased number of stage 3 and 4 colorectal cancer diagnoses, whereas these modeling studies also show that delays of greater than 12 months will actually lead to a significantly increased number of colorectal cancer deaths. But how did COVID-19 affect patients at high risk? And for that, our group recently published a report that just came out a month or two ago in Cancer Prevention Research, looking at the COVID-19 disruptions to endoscopic surveillance in Lynch syndrome. And what we found was that during the height of the COVID-19 pandemic, during the spring of 2020, approximately 11% of our institution's Lynch syndrome cohort had endoscopic surveillance that was canceled due to the shutdown related to COVID-19. Of all these patients that were canceled, fortunately, 85% of these patients were successfully rescheduled and had their procedures performed within 6 months. However, concerningly, 15% of patients actually still had not rescheduled their procedures 6 months after the initial cancellation. What we found was that actually younger individuals were less likely to reschedule their procedure, and also males were also less likely to reschedule their procedure. However, other factors such as race, gene mutation, and personal history of cancer or personal history of colorectal cancer were not significant. Over here on the right, you can see the probability of rescheduling based on age, and you can see, of course, that as age increases, the likelihood of rescheduling also increases. So this did help us identify some groups that may need some additional outreach to facilitate rescheduling their surveillance, which of course for these high-risk individuals is extremely important. So that was a whirlwind tour of colonic surveillance in high-risk young patients. I could have talked for an hour easily on this topic, but given the time limits, I'll stop the presentation here. I am looking forward to taking questions from anybody that may have them during the panel discussion. And I thank you very much for your time and attention.
Thank you so much. Thanks so much, Dr. Greenwald and Dr. Katona for these wonderful talks. So I had a question. I know there are some questions from the audience as well. How have the rates of colonoscopies recovered now that we are in May of 2021? Obviously, there was a very, very sharp drop-off and beautiful studies presented by both of you. But I wonder, how is New York doing? How is Philadelphia doing currently?
I can certainly take New York, and thanks to everybody for the really wonderful presentations and for this entire conference, which I think is really tremendous. So we never stopped, as I said during my presentation, and then we have recovered quite a bit. We're probably between 90 and 100% of our pre-COVID volume, and in some places we've actually exceeded 100% because we're catching up at this point, and we've expanded capacity, so we're working in the evenings or on weekends more than we used to. We had, just in our own hospital, it's a big hospital in New York, I mean, we had several thousand cases or people in terms of backlog, and we're still sifting through our backlog. And that has been balanced by patients, some of whom are very eager to come in, and we're of course encouraging that. And then some people who up till very recently have been very frightened, very scared, and it's taken a lot of reassurance to convince them not only that everything was safe, but that, as I said, that taking care of their regular healthcare was really important.
Yeah, I completely agree. In Philadelphia, we're up to 100%, if not over now. Again, trying to play catch up. I think that the people's reluctance to get their screening procedures is definitely dissipating as more and more people are getting vaccinated as well. I think especially in the fall of last year, there was a lot more hesitance, but now, I'm seeing much less, especially with the increased vaccination. So I think, we're definitely catching up. I think, there will be a group of people though that, probably, still have not gotten the appropriate screening. And so I think there certainly are people that, will need, targeted outreach to make sure that they get in and get their appropriate screening done.
And I was actually going to ask you that. So in those 15% of patients with Lynch who sort of dropped off and didn't reschedule, are you planning on sending them anything to do some kind of outreach? We were sort of considering that at our institution, and we're not sure how other institutions are dealing with that.
Yeah, so we had initially had a process where everybody that was canceled had some kind of standard outreach that was performed, but at least for our high-risk patients, we're just we've given our administrators a list and have told them to continue nagging and calling and to make sure that we can get them in. And since that paper was published, I think that data was through like December. I'd say probably half of the people that hadn't rescheduled we've actually gotten them in to get their scopes. So I think we're making progress.
Yeah, and I'll say that we this has been very much of a hand-to-hand kind of thing. So we put together lists and we sent like emails and text messages and these MyChart messages to people, and some of them worked, but the most impactful was when the physician or somebody the patient knew actually called and spoke to them. Makes an enormous difference.
And then we have an audience question from Carlene Taylor, who said, my 22-year-old son was diagnosed, he passed away at age 23. I'm so sorry to hear that, with a rectal cancer primary. As we saw, the rectal cancers are the ones that are really increasing in the young patients. With 3 other children, age 19, 21, and 25, who all had colonoscopies at that time that were negative, and then had sigmoidoscopies again a year later in 2017. So given this early onset rectal cancer, let's presume that it's a genetically negative rectal cancer. When should these young adults be scoped next? What should be the frequency of colonoscopies?
Yes, I'm happy to answer that. And Carlene, I'm very, very sorry to hear about your son. It's just, must have been an incredibly tough time for you and your family. Yeah, I think in this, in the setting of, I think it's an important point to make sure that, we're talking about the genetically negative situation. I mean, for, your family with this type of a family history, if your son who passed away didn't have genetic testing, I think it would be very important for other members of the family to undergo genetic testing. But assuming that all came back negative, I think in these situations, oh, I see. It looks like it was genetic testing was negative. I think in these situations, there's really no evidence to support repeating colonoscopy more frequently than every 5 years, assuming that everything looks normal. And I think we oftentimes, these are cases where we actually see people getting overscreened, in my opinion, and I think a lot of people are nervous, but screening itself does have some small risks associated with it, and so I think that in these situations, I do like to follow the data, and I would avoid overscreening, but I think every 5 years, as long as things are negative, would be reasonable. Dr. Greenwald, do you have any other thoughts about that?
No, I totally agree. First of all, my condolences to the family, and obviously a very difficult time. And I agree with you totally. Genetically negative, you'd follow the guidelines, which would suggest every 5 years. That may be difficult to do. I understand how difficult that might be to do, but those are the guidelines. And remember, the tests that we do are not all free of, complications and problems. Obviously rare, don't want to scare anyone off, but we only want to do tests that are indicated.
So thank you so much for joining. Great talks. And now I want to introduce our next 3 speakers who will address genetic testing. So first off will be Robin Dubin from Alive and Kicking, who will talk about how to increase access to genetic testing for Lynch syndrome. Then Dr. Melissa Frey from Weill Cornell, who will address something really fascinating called facilitative genetic testing. And then last will be Dr. Whitney Jones, who will address action at the state level, the role of HCRA, call to action for EHRs and genetic testing. So I welcome these next 3 presenters, and then we'll meet again at the end.
Hi, I'm Robin Dubin. I'm the co-founder and executive director of Alive and Kicking. These are my disclosures, and I'm here to talk to you today a little bit about the knowledge gaps as it relates to genetic testing in hereditary colon cancer. Alive and Kicking's mission is to improve the lives of individuals and families affected by Lynch syndrome and associated cancers through research, education, and screening. So let me start by talking to you about what is Lynch syndrome. So Lynch syndrome is a genetic condition that increases a person's risk for certain cancers. It is the most common inherited cause of colorectal and endometrial cancers. Many individuals with Lynch syndrome mutations develop related cancers at a very early age, much younger than the general population. So screening for and earlier for patients with a known Lynch syndrome mutation. One of the unknowns is that as early as 2017, studies indicate that the population prevalence of Lynch to be 1 in 279. This means that 1 in 279 individuals has a Lynch syndrome mutation, although 95 know they have it. So we know that one of our knowledge gaps is understanding your family history and whether you are a carrier of one of these hereditary cancer genes. These genes are autosomal dominant, meaning you have a 50-50 chance of inheriting a Lynch mutation from one of your parents. So to understand the knowledge gaps, we have to look at both the patient and the clinical communities. Within Alive and Kicking, we do a lot of our work in both communities and clinical communities. And so there's a few things we focus on. In the patient community, programming and resources focus on patients and families that have already been syndrome, both those that have had cancer and are cancer survivors and know they have Lynch syndrome in the family, and then also those that are called previvors, those that know they have a Lynch syndrome mutation but have never had cancer themselves. But we also know that over 95% of those affected by Lynch syndrome, those 1 in 279 individuals, over 95% of them don't know they have it. So that is what we look at as the undiagnosed community in the general public. And reaching that population is much more difficult. those are not cancer patients that are coming in and seeing oncologists and seeing specialists for cancer care. So we rely a lot on understanding your family history and the primary care community within the clinical communities. So clinical communities that we focus on, besides oncology, genetics, and genetic counseling, and then the specialists that Lynch syndrome need to see to get all of their cancer screenings, like GI doctors, OBGYNs, urology, and oncologists. We also have to focus on what's happening in the primary care setting. When unaffected individuals or undiagnosed individuals are going in for annual visits or checkups with their primary care physicians, are they being asked family history questions? Is the knowledge about hereditary cancer in the primary care setting one of the gaps that we need to address? One of the reasons why we have these gaps is also understanding the importance of genetic testing and family history. So we do know that Lynch syndrome and other hereditary cancer mutations are not regularly being diagnosed at the primary care level before a cancer diagnosis. Family history isn't regularly being discussed at the primary care level. And so to continue to move the needle forward, expanded efforts to diagnose Lynch syndrome in healthy cancer are needed, rather than relying on identification of Lynch through new cancer diagnosis. To talk about education about germline genetic testing and why it's important. Germline genetic testing is looking for these gene mutations, these hereditary cancer gene mutations in a person's DNA. Whether they've had cancer or not, they need to be diagnosed with a Lynch syndrome gene mutation. You do need testing. So they're important. Why is it important to know that you have a Lynch syndrome genetic mutation? Because two of the main reasons are the need for annual screenings, guidelines in place for the types of cancer screenings that with Lynch syndrome have, they need to get. It includes colonoscopies, endoscopies, and other types of cancer screenings by a wide variety of specialists. Those guidelines are updated often by the NCCN, the National Account Network, and those are the guidelines that clinicians use to guide screening for individuals they've had cancer. And the other reason is family members, because if an individual is diagnosed with a Lynch syndrome mutation, then that means that it is in their family. So there are many other family members that are likely positive for the same Lynch syndrome gene mutation. And those family members need to be educated, informed, and counseling and genetic testing. So what happens when someone gets cancer diagnosis in one of the cancers that is common in Lynch syndrome individuals? There are different types of tumor screening options, and we're going to discuss why that is important. So our understanding of cancer continues to evolve at a rapid pace, and the identification of biomarkers that can play a role in determining patient care is a significant scientific advancement and one that requires continued education. MSI, or microsatellite instability screening, has long been recognized as important in the care of patients with colorectal cancer or endometrial cancer. And high frequency MSI high testing or having a microsatellite in stable high tumors is now recognized as a potential for germline mutations in certain DNA misrepair genes associated with Lynch syndrome. And so a recent study has shown that Lynch syndrome was identified in 16.3% of the patients with MSI high tumors and 1.9% of the MSI indeterminate tumors. With Lynch syndrome with MSI tumors, 8% that were tumors other than colorectal or endometrial cancer. In patients with non-colorectal cancer tumors, 45% of them didn't meet the Lynch syndrome genetic testing criteria on the basis of personal and family history. So identifying tumors that are microsatellite is important for several reasons that we will go into further. But a big one of them is that there's a chance that those patients have Lynch syndrome in their family. So one of the things we have learned that's important is that MSI high are a biomarker for cancer response to immunotherapy. And that means that anyone with MSI high tumors are exceptional responders to PD-1 inhibitors, are immunotherapy products, and Lynch syndrome patients primarily have MSI high tumors. So the treatment for Lynch syndrome patients with an MSI high cancer has had exceptional responses, and we know many patients who have benefited greatly with these immunotherapy products. So it's a very important treatment, but you can't get this treatment unless you are aware of your MSI status and you've had biopsy on your tumor. So one of the things resulted because of these advancements is that NCCN guidelines indicated that they screening of all patients with colorectal or endometrial cancer for evidence of mismatch repair deficiency, either by microsatellite instability or loss of MMR protein expression, and to maximize sensitivity for Lynch syndrome detection and simplify care processes. So universal tumor screening of all patients would indicate for immunotherapy, but it would also indicate whether these patients likely have Lynch syndrome in their family and can then be referred to genetic counseling and genetic testing for Lynch syndrome, which can in the future prevent or detect early cancers in that individual and their family members. But we have found that while universal tumor screening is part of the NCCN guidelines, it is not regularly happening. And many patients in Lynch-associated cancers will not be screened, will not have tumor screening, and therefore will not be diagnosed with the Lynch gene mutation that they likely have. So some of the things that Alive and Kickin is doing to work with the research community on trying to make a difference in this includes our work developing the HEROIC registry. So the HEROIC registry is the first of its kind patient-centric genetic database that will enable patients to take an active role in furthering research into this genetic. It allows patients to contribute medical information and their experiences living with Lynch syndrome and its associated cancers to help researchers develop new treatments, understand the Lynch gene mutations, write medical papers, and conduct further studies in patients provide this data, we can help determine and shape the type of research studies to be conducted. We've recently transitioned the Heroic Registry from one platform to a platform on LunaDNA, and we just relaunched the registry on the new platform. And that will enable us to gather record genomics data as well. And as you can see, we do have very interesting data in the registry. It is real world data, and as of last year, before the technology into the new platform, this is a piece of information. This is a kind of a brief look at our patients in our registry. So these are all patients that have been diagnosed with a Lynch syndrome genetic mutation. 20 have had colon cancer. 15% have had endometrial cancer, but 27% of them never had cancer. They are Lynch positive patients who are being actively screened and watched very carefully, and they have never had cancer. But you can also see that there is a wide variety of cancers these patients have had, and a large percentage of in the database, in the registry, have had more than one cancer. So we have a rich group of data that we are gathering and continue to gather and continue to have patients sign up for, we are using for research. So how is it currently being used? Registry and started building up the data. Since January of 2018, we've had 7 different abstracts about the registry and the data within it, accepted as posters at medical conferences. We've had engagement and collaborations, outreach from 22 different potential studies, including requests for enrollment for participants into studies, requests for support, requests for collaboration on submission, including major roles for Alive and Kickin'. So having the patient data gathered in this way by a patient advocacy organization has really advanced the opportunity for our patient community to participate directly in ways that are going to have a direct impact on their patient care. Some of the other ways Alive and Kickin' has impact in the community include things like our Living with Lynch patient workshops in collaboration with the Colon Cancer Coalition. We have initiated and developed our patient workshops. We launched it in 2019 at MD Anderson, and it was a small group of Lynch syndrome patients gathered together to meet with clinicians at MD Anderson, to have roundtable discussions and do patient education. We participated in the Colon Cancer Coalition Year and Year Houston race by getting a group of Lynch syndrome patients together to do educational outreach at the event. We captured patient stories on video. We are able to use those patient stories to have impact on social media and to the general public. We attend patient education and outreach programs such as the Early Onset Summit that we're all attending now. We attend academic conferences. We work with advocacy partners, industry partners. We often speak to both patient groups, clinical groups, and at other conferences, and all with advocacy related to policy patients. And actually right now, if you go to the livingwithlynch.org website, we have our Living with Lynch participant application. So if you or any Lynch syndrome patients you know are interested in participating in person in our first in-person event of 2021, a small group of patients in September in Columbus, Ohio, at the Ohio State Comprehensive Cancer Center, and we will be accepting applications, I believe, through the end of May, and be interviewing, engaging a small group of patients to attend in person, but we will webinars online. We'll open that up to the larger online patient community to learn and have some patient education there. So thank you for listening. I will be live for questions, and you can learn more about genetic testing, what we provide.
Thank you for the opportunity to speak today. My name is Melissa Frey. I'm a gynecologic oncologist at Weill Cornell Medicine, and I'm going to be talking about facilitative genetic testing. Currently in the United States, about 1% of the population that can cause a familial cancer. Unfortunately, more than 80% of those affected with these mutations are not aware. Why is it important to identify these people who are carrying mutations, but who are not aware of their underlying mutations? Well, let's think about a syndrome like Lynch syndrome. If we identify that a person has Lynch syndrome, we offer that person screening and prevention for gastrointestinal cancer. For women with Lynch syndrome, we can offer screening and surgical prevention of uterine and ovarian cancer. Has a mutation like Lynch syndrome and does develop a cancer, that often affects the way we treat the cancer. We can often provide individualized or targeted therapy. But I would also argue that there's one more important implication of finding out someone has a mutation like Lynch syndrome that we often undervalue. What is that? Cascade testing. A cascade is a process whereby something, typically information or knowledge, is successively passed on. What is cancer cascade testing? Well, this is when the knowledge that we're passing on is information about hereditary cancer. So we're offering relatives who are also at risk for carrying the mutation the opportunity for genetic assessment. Let's take this family as an example of the power of cascade testing. This is a woman who has colon cancer and on genetic testing was found to have Lynch syndrome. We know that this syndrome is inherited in an autosomal dominant way, and that means that each of her first degree relatives has a 50-50 chance of having a mutation. So that's parents and children. So all of these first degree relatives can undergo genetic testing. If we find came from her paternal side or from her father, we can then further cascade and offer his first degree relatives genetic testing. And you can imagine that with multiple cascades of this original cascade, we can have many family members who may also carry this mutation and may also be at risk for cancer. And this is critical because when we identify relatives who have a mutation, we also can offer them the opportunity for cancer screening and risk-reducing surgery. How does cascade testing work in the real world? So we often have a person who has a cancer. That person undergoes genetic testing and we find a mutation. And then ideally, we would offer cascade testing to that person's relatives. Unfortunately, we know that less than a third of relatives actually end up undergoing genetic testing. And so these are people who have up to a 50% chance of getting the same mutation, and still very few are actually undergoing genetic testing. Why is this? Well, let's imagine an example. We have a person who has a new diagnosis of cancer and a new diagnosis of a hereditary cancer syndrome like Lynch syndrome. This person is coping with a new cancer diagnosis, preparing and recovering from surgery, often preparing for treatment like chemotherapy, navigating the work and the financial toxicity that can accompany a cancer diagnosis, and also considering risks for other cancers. While doing all of this, we're asking our patients to take on the full responsibility of cascade testing. And what does that mean? Contacting to disclose their own cancer diagnosis and their own genetic mutation, something they might not be ready to share yet with relatives. We're also asking our patients to explain these complex genetics to their relatives. And then also, they're going to share this information with their relatives, and their relatives are then going to want finding out how to get tested. And they're going to ask, our patients, what should we do? How do we get tested? And currently, this responsibility or burden falls completely on our patients. And we really, tell them, unfortunately, this is something that the system is leaving up to you. So at Cornell, we decided to sort of challenge this paradigm that cascade testing responsibility of the patient. And we proposed a pilot project called Clinician Facilitated Cascade Genetic Testing, where we tried to have our medical system take on some of the responsibility for cascade testing. All patients at who had a new diagnosis of a cancer-associated mutation were invited to participate. Those interested met with our genetic, and we had to determine which of their relatives should undergo testing. With our patients' permission, we contacted their relatives by telephone and reviewed the that ran in their family. And for those who were interested, we offered them genetic counseling. After genetic counseling, if the relatives were interested in testing, we mailed them a saliva kit to their home with a self-addressed to the testing laboratory, so they could complete the testing from the comfort of their own home. And then we followed up with to review the results. And for those relatives who shared the familial mutation, we talked to them about what risk-reducing recommendations exist to prevent a cancer or diagnose it early. What did we find? Well, we know that historically, less than 30% of relatives undergo cascade testing. And in our pilot study, we had approximately 60% of relatives successfully undergo cascade testing. So can testing identify everyone in the population with a germinal mutation? We were clearly looking at a very small kind of pilot just at our institution. Well, we teamed up with a group at Memorial Sloan Kettering to combine our model with some mathematical modeling that they were doing. And they were looking at the idea of peridiagnostic genetic testing. So that means if you take all people with a new cancer diagnosis and do their genetic testing, and then for those who have a mutation, our pilot pathway of clinician facilitated cascade testing. And based on modeling, we actually found only about 10 years to identify all 4 million people in the United States living with germline familial cancer syndromes. And so these are an exciting project and just shows that if used correctly, the combination of testing at time of cancer diagnosis and cascade testing is quite powerful. So if we can identify these family members, then the logical next question is, so will relatives act on the information? So is it worth it to identify? Is it the health of these relatives? So we performed 2-year follow-up on our pilot study, and we actually found that 75% of relatives had undergone at least one cancer screening intervention. That includes breast screening, gynecologic screening, prostate screening, gastrointestinal screening, and dermatologic screening. 14% of relatives had undergone a risk-reducing surgery. So that was mastectomy, sublingual oophorectomy, and hysterectomy. And interestingly, 44% of patients reported that additional relatives in their family ended up undergoing cascade testing as a result of their testing. This 14 additional relatives getting tested and 6 additional mutation carriers getting identified. And this is what's called sort of the cascade of the cascade. So sort of in summary, we know that when the medical team participates with our patients in cascade testing, we can increase rates from about 30% to up to 60%, which is very exciting, and that 75% of relatives in whom we diagnose mutation will act on this information. So I hope that I've shown you that cascade testing is critical, but what else can we do to facilitate genetic testing? So one issue with cascade testing is that in general, it comes after a cancer diagnosis. So it really relies on this first person getting cancer and then finding out his or her mutation. And wouldn't it be great if we could have found this person before her cancer diagnosis and not wait for her cancer? So how can we do this? How can we find individuals who are at increased risk for hereditary cancer prior to a cancer diagnosis? And I think the answer is family history and taking a really good family cancer history. Most clinicians would agree that family history is important. However, I think most would also agree that there's wide variability in the scope and accuracy of the histories that we collect. When both patients and providers have been asked about what are barriers to collecting good, accurate, and sort of wide scope family history, the barriers they mentioned are lack of provider training, lack of appointment time. Some studies suggest that you need at least 30 minutes to take a family history, and on average, private are spending less than 2 minutes on a cancer history, inconsistent documentation in the electronic medical record, and then also we don't give patients enough time to collect their family history. Patients are often at a busy appointment where they have a lot they want to share with their physician, and we're asking them on the spot to remember their family who may have had cancer. And this is something that I think really, improved if we gave people the opportunity to discuss with family on their own time prior to the visit. One suggestion as far as ways to improve our ability to collect a family cancer history or family health history is using information technology. And that's because information health technology improve documentation, workflows, the quality of care, patient safety, communication, and can provide clinical decision support. And specifically, one can imagine that a well-designed health IT application or website could collect personal and family history of patients at risk. It could calculate disease using known risk models and algorithms. It could coordinate genetic testing, communicate results with patients, and then ideally share those results with relatives, thus helping with cascade testing. So we performed a review to try to determine, are people using information technology to collect health successful? We found these studies, which have all looked at using some type of health IT to collect a family cancer history. And if you look at sort of percentage of completion rates, it's high in the 80 percentiles. When we look at specific tools, we could basically divide the tools into 3 categories. We can email patients a survey to do at home prior to their visit. We can complete a survey in the office, often on a tablet that we provide while a patient's waiting for their physician. Or we can set up kiosks or stands in the office where a patient can complete the family health history. And you can see that in general, the majority of patients were able to successfully complete these types of health IT tools for family cancer history collection. And on average, it took about 31 minutes. So I think patients are spending a lot of time on this. And we found the feedback in the few studies that included patient feedback were sort of very positive. So we decided to launch a similar program in our office, where patients could input data through a website prompted by questions. The website could then use validated cancer and genetic risk modeling to run risk assessments. And then the physician and the patient would be provided at the office appointment with a pedigree. So that's sort of a visual review of the patient's family history, risk assessment for cancer, and risk assessment for mutation. So we could look at the patient in front of us and tell us, based on the best modeling we have, this is your risk for having a specific cancer like breast or ovarian or pancreatic or gastrointestinal. And this is your risk of having a specific mutation like a Lynch syndrome mutation. So we enrolled all women who were presenting to us for new patient appointments, and we randomized them to one of 3 arms. Usual care, that's where we collect family history as part of the face-to-face interview. We offered them this web-based tool to complete at home. We sent it via an email. And then we also offer them to complete it in the office on one of our office computers with someone from our team available for questions. And we really wanted to evaluate, were our patients able to complete the tool and what was the quality of the history that we collected. So we found that, surprisingly, only 60% of patients completed the tool when we sent an email, whereas the majority completed the tool when we offered it to them in the office. And some follow-up interviews revealed that, this was only available, had to be done on a tablet or a standard computer. It couldn't be filled out on a smartphone. And for many patients, that's a serious barrier. Also, when we had patients complete this at home, there was no option for questions or real-time feedback. And so if they didn't understand something about the app, it often caused them just to not answer the question or not even complete the tool. We were excited to see that we were able to collect information on a much greater number of relatives when we used this tool. So you could see that we were often collecting information on under 5 family relatives versus via the email or the office, we could collect sometimes information on more than 25 relatives. And we were able to collect information on 1st-degree relatives, 2nd-degree relatives, and even a good number of 3rd-degree relatives when we use this web-based tool. So what's the future of electronic tools in genetic medicine? Our pilot study? Well, and I think we have to think about all patients scheduled for medical appointments, whether that's with a gynecologist, a primary care doctor, whether that's patients going for a mammogram, because these are patients who really might be able to benefit from some cancer risk modeling. We should offer them something to collect their family history that's convenient. And so we know from our study that has to be smartphone accessible, because sort of forcing patients to log on to a standard computer is going to really limit the success of any tool that we try to pilot. We got the feedback from patients that we want feedback. This is hard. It's especially COVID when we're trying to limit the amount of time patients are spending in an office and in contact with medical personnel. But this really presents the idea of artificial intelligence, because artificial intelligence is now being used to sort of scale communication, and natural language processing allows people to actually with artificial intelligence programs, and that can actually really successfully answer questions. And this type of study for genetic medicine has been piloted and has shown to be successful. And then finally, I would argue that it's great to family history, and we absolutely need to be doing that, but it really only has use if it can result in better care for our patients. And so with family history of cancer, patients meet criteria for testing, and if they do, they should have to take the next step, which is using these tools to do risk modeling for our patients, educating our patients if they are at increased risk for a certain genetic mutation, and then even coordinating care. So if someone, perhaps our tools can order the patient a saliva test or a blood test prior to even their physician visit to get the process of genetic testing really facilitated in a time-efficient method for our patients. So in sum, cascade testing is critical. However, for cascade testing to be successful, the medical system must participate in the process. We really have to change the paradigm of cascade testing. Health information technology can identify individuals at risk for cancer based on personal and family history, and future health information technology hopefully will focus on collecting personal and family history and facilitating genetic testing. Thank you very much for the opportunity again to speak today. And I want to thank.
Hi, it's Dr. Whitney Jones from the Colon Cancer Prevention Project in Louisville. Today, I have the opportunity to speak about genetic testing and improving evidence-based uptake at the state level, actions we can do to advance that issue. So thanks so much for taking time to spend today with us. Here's my financial disclosures. So genetic panel testing, research to implementation. Why is there such low utilization? Particularly when BRCA affects 1 out of 400 women and Lynch affects 1 out of 279 people. It's a very common issues. And again, there's reasons both at the state and national level why we have this. There is tons of research about the importance, the benefit, how it can impact outcomes, the importance of testing. But again, when it sits in the bundle, sometimes it sits alone. To really translate, we must improve the awareness out at the community level. And people have to have awareness and comfort, but unfortunately, I think amongst most practitioners, there's low awareness and there's low comfort outside of academic centers. And there's really shown here. Number one, this information is moving at bullet pace like a bullet train, and it's very hard to keep up with all the other issues. Secondly, there's really been a lack of education in the medical education, the postgraduate education, and the continuing medical education. But I would say that's really increased over the last several years. So people doing continuing education should get a piece of that. And then a lot of people really don't understand the financial implications of the test. What's it going to cost? Do they get a crazy explanation of benefits letter? You know, they just don't have as much comfort. And as a result, what we lead to is a decrease in action. We don't see nearly as much action, and that's less than 5% of primary care practices, about the same in gastroenterology. OBGYN does a better job, and probably, and paradoxically, oncologists are picking this up at the end of this supply chain. So we've really got to wrap our head and rework this paradigm. As we know, in cancer, it's extremely important to test all people under 50. This was Heather Hampel's study at Ohio State. And as you recall, about 16% had a hereditary condition, genome testing. 14% of people had a first-degree relative, and another 14% had a first-degree relative with advanced adenoma. So, but between those, 4% of people with early age onset cancer had a family history or genetic risk factors that would have altered their testing time and testing choice. So This is critical, I think, out there, particularly with regards to under age 50 colorectal cancer. But the new clinic study that just came out of the clinic suggests that, in fact, 1 in 8 solid tumors, so just a little bit up from 1 in 6, has a hereditary component with a pathogenic mutation in 13% of all solid tumors. The penetrance was high in 38%, moderate in 34%, low in 16%. But the predictors of the positive genetic test, early age diagnosis of cancer. So that was critical. And what we're learning is sex, stage, family history were not as predictive as what we thought. So I will be telling you, look in the future for universal solid tumor testing for genomic and inherited issues in your state. Again, we'll have to watch out for these variants of uncertain significance. The rate are much higher. These will turn up to be pathogenic when we pieces. And in terms of early age onset colon cancer and its overall states out there, now in Kentucky, Mississippi, and West Virginia, we're used to this. We're used to having very high rates of cancer incidence and mortality. But I want you to look at this slide that looks at the burden of cancer defined by rank of incidence and mortality overall to the rank in under age 50 colorectal cancer. And these are all derived from the American Cancer Society. And what do you know? Out of the top 10 states with high burdens of colon cancer, 8 of those top 10 are also in the top 10 for under age 50 colorectal cancer incidence. Likewise, for the second 10, 7 out of these 10 states with high colorectal cancer burden overall, against incidence and mortality rank order added, are also high with under age 50. So this is expected, and who wouldn't expect it? To me, it says that if you are in a top colorectal cancer and mortality state, there's a great likelihood that this is related to your colorectal cancer work, and that colorectal cancer screening and prevention starts earlier, particularly individuals, as well as messaging to impact behavioral issues. So again, I think there will be only more and more bricks in the wall pushing towards wider adoption. So in Kentucky, we, as you know, we're #1 in the nation, although we have improved to 20th best in screening, depending on what year you're looking at. And so we were perplexed by this. So we looked back at Kentucky here in the red for under age 50 colon cancer incidence versus the national level of under age 50 colon cancers, as we found in the SEER data. And what you can see is even as back as far as 2000, we had a 20% increase over the national average for under age 50 colorectal cancer. And this is only worsening with time. And so it's part of the answer of why genetics are going to be so critical, because we've suspected a Lynch syndrome founders of Kentucky for quite some time, and we're getting ready to go into some studies. They're going to help delineate that. But I would suggest to you, if you have high levels of under age 50 colon cancer, that's directly leading to your high incidence and mortality rates for your overall burden. You should know what this looks like for your own state, particularly if you're in one of those top 20 states trying to advance work in this area. So in Kentucky, we've sort of had our eyes on this for quite some time. And here's a little synopsis of the state legislative actions. So our pictures, this is our normal vision of DNA and hereditary cancer risk assessment. And down here is more of a scatter plot and a Sanger plot. And again, I do this only to let you know that our process of DNA and molecular diagnostics are getting ready to take a huge leap into hyperspace, if you will, with advances. But what we did, again, we knew genetics were important. We knew it was an important piece. So actually in 2017, our organization partnered with the Kentucky Society for Clinical Geneticists, expanded genetic counselor licensing where they can be independent and they can bill on their own. They did not have to be embedded within a healthcare system. And we thought this was important because we could potentially increase workforce. As you know, the wait for genetic counseling and testing is a long time. And also for doctors who are in practice who are not employed by networks, getting those guys access outside of network we thought was important. Again, in 2018, ACS dropped to 45. And remember, ACS is a good friend in terms of guidelines because it also recommends genetic testing for those who meet criteria. So figure out how you can work the ACS in state. In 2019, we were a little bit surprised that if you had a history for breast and ovarian cancer, that you could get genetic testing free of as a preventable service. But for Lynch syndrome or the other colorectal or the many other types of cancer diseases, that wasn't possible. So we were able to pass what we call the Access Genetics Testing Act, all A's, G's, and T's for you genetic wonks out there. And what this basically said, if you meet NCCN guidelines for a cancer, including colorectal cancer, that this is going to be treated like a preventative service along the lines of hereditary breast and ovarian cancer syndrome. So Lynch syndrome, polyposis syndrome, and it was to be a no-cost share preventative service. In 2020, we followed that up and guaranteed the coverage for this NCCN panel testing in our Medicaid populations through the Medicaid managed care organizations, including stool DNA, which I think is part of the genomic revolution. And so $21 to $23 billion in screening as well as genetic testing coverage for people in the Medicaid world. We upped multi-gene panel testing to work with our Kentucky colon cancer screening program, if appropriate, indicated, and met guidelines. And we've had an updated Department of Insurance opinion around testing and coverage thereof by universities and, sorry, not by universities, but by insurers. Thank you so much. And again, we've been working on coding for quite some time, and we've had screening for all for several years and updated ages. But the key for this is having the laws is not enough. This is a backhoe for those of you guys who aren't into farming and mechanics, and we backfill these legislative accomplishments for over 5 years because of non-participation by certain insurers, poor uptake by health systems where they haven't been billing and coding appropriately. We're working a lot with health systems now on educating the providers they employ and the health systems and endoscopy suites or offices in order to make this a reality. And then the other thing in Kentucky is we have been for almost 6 years now implementing what we would call the on-time, early, and current messaging package. So we've expanded every single bit of messaging that we do to include what we call the early messaging package, talking about symptoms, family histories, and lifestyle modification to those. We blend that into the package when a person reaches their mid-30s, trying to find those high-risk individuals that may be high risk for screening, but also potentially qualified for genetic testing, and really getting that information out to them for multiple years, but well in advance of when they need it. And then this on-time wants to capture not only normal risk individuals at what will soon be a unified screening age at 45, but also individuals at age 40 or sooner, depending upon when polyps affected their family. So this is one of the issues that I think at every state level, you should begin to implement in a way this early messaging package where you're talking about family history, you're talking about the importance of genetics so as to increase the likelihood. So in addition to our legislation, we also did a lot of communication measures, probably more. Again, we started the implementation. This is how we see colon cancer prevention. It starts with diet and nutrition and family history and genetics and lifestyles. We wanted people to know about the symptoms. This is a 45. Here's a 45, folks, because we've got ourselves a four-wheeler here and wanted to put a. And over here on the final one, we have our poster in Spanish where we distribute that out amongst our Hispanic communities. So again, we're happy to share these with you across the nation. You can get your own logo up here in the corner and get these out. These posters have been taken up all across the United States and even some in Europe. In addition, the project put out a documentary into Preventing a Killer. It was a focus on underage 50 colorectal cancer in Kentucky, brought people together from Appalachia as well as urban areas to talk about colorectal cancer. After we passed the Access and Awareness to Genetic Testing Act, we had Heather a webinar to introduce genetic testing to practitioners across the state. It's still available on YouTube. A lot with our state hospital association over here to get them to increase their genomic and genetic footprints in their organizations as this new fourth wave of medicine comes upon us. We've been linking industry websites to our webpage because the industry around genetic testing has become very active and offering testing and evaluation those to them. We'll be doing in 2022 a evaluation for universal colorectal cancer tumor screening for Lynch syndrome to see if we're following NCCN guidelines and we have a high uptake. We also want to look for disparities between geography, racial groups, ethnic groups, and sexes about when this is utilized, as well as the site of service, universities versus community hospitals. We were real happy last week to see the medicine genetics came out that talks about genomics and genetics, because clinicians have got to get used to this, and not just the end of the line where oncologists and medical geneticists are, but more importantly, where primary care physicians live. So I want to end this by letting you know that if you're not thinking genetics, you better get ready, because there's going to be more strategies going to appear for normal risk individuals. So you got to be prepared, proactive, and pragmatic. And over here on the left is a use of various liquid biopsies for treatment stage. And I like to think of it like a CAT scan. We slice people in terms of their anatomy and to allow it to slice the cancer experience over time, to where we're not only going to have early intervention with early detection using cell-free DNA or what's called circulating tumor DNA. We'll also use this in diagnosis. People have symptoms, but the imaging isn't there. We'll determine recurrence, minimal residual disease, metastatic disease, and then refractory disease leading to precision medicine. So again, right now we have stool DNA with Cologuard and Exact Sciences, but we will see expanded stool DNA tests, I'm sure, in the future. We'll begin to see multiple colorectal cancer specific blood tests, including septic and multiple iterations of that. One-time genome sequencing is still expensive, but don't expect it not to be on the list 5 and 10 years from now. But the real place I want you to wrap your head around are these liquid biopsies, these cell-free DNA, and these are going to be called multi-cancer early detection tests. Players internationally have already teamed up in an alliance to get this pushed over the finish line at the C billing level. So this will be available to Medicare recipients. These will be out commercially this summer, and you need to figure out how you incorporate early detection strategies as a complementary test potentially to the screening that we already perform for cancer. And again, overall, understanding a person's family history is really how we understand what risk is, so we can utilize evidence-based testing, including genetic testing and multi-omic testing, to increase the ability to treat, identify, and better manage folks through the genetic lens. So I want to thank you guys so much. Happy to answer any questions, and I'm happy to answer any on email as well. I hope you have a great rest of the conference, and thank you so much.
Thank you so much for these really, really wonderful talks. And, you know, listening to all three of you, I just have to know the power that the three of you bring to the table in terms of Robin with patient advocacy, Melissa with bringing together really patient and provider advocacy, or provider facilitated patient advocacy, and Whitney, but you sort of the government state level that can impact this. So how can the three of you, right, representing society at large, work together better to get this message out?
Well, I'll start from the state level. I think that if you're in the genetic business, you know that this is coming. This is a tsunami. Our colleagues who are struggling right now in the offices with electronic health records and the deluge of information, I think that we're going to have to find a middle ground. I love Dr. Frey's talk, because I think that is, we're going to have to become hybrids. We're going to have to use AI and informatics to identify, collect, and present recommendations to the primary care physicians, because that's not going to be possible. And unfortunately, our genetic resources continue to be further embedded in oncology, when in fact we need them further in the front line to help primary care physicians with that all-important identification of risk through family history and through appropriate testing guidelines, because physicians can't do that. So what I think will happen is, I think if you really want something done, you got to measure it and pay for it. So I think eventually what we need to do is benchmark the collection of family history and prepare for it to be automated as a benefit to primary care physicians. Because again, if it's not primary care, GI, OB, family practitioners, nurse practitioners, urologists, dermatologists, if they're not out front doing this work, then it's going to be the oncology world. And again, that's a great place for it to be, because now we understand more, but that's not where our resources need to be. So I think at the legislative level, bringing in clinicians, bringing in advocacy groups like Robin's group, great data from Dr. Katona and everybody, I think we have to benchmark it like we did adenoma detection rate if you really want to make a change.
I agree. I think the work we did is very exciting, but it's not exciting if it just remains a small pilot at a single institution. And so I completely agree that we have to think bigger sort of policy issues. How are we going to test patients across state lines when there are rules in place? How are we going to test patients and have insurance pay for it, depending on who's testing and where the testing is being done, and whether there's a family history, or does the patient's insurance affect what company, et cetera. But then also, I think, what I found just by doing these pilots is if you're going to ask to or want to recruit the primary care doctors and the primary OBGYNs who already have very busy practices, we can't make this difficult. We really have to make this user-friendly and easy, and we can't really put the onus on providers who are, again, already very busy to sort of figure this out. We have to make it easy, and we have to make it easy for our patients.
Yeah, I agree as well. I mean, I think it's one of the reasons why, besides providing resources for the patient community, that we've really made a strong effort to be connected in the provider communities and industry as well, because that is where a lot of these advances are taking place. And we want to make sure that we are up to date on knowing about what is happening in terms of treatment, in terms of testing, so that we can make sure that our patient community is aware of it. And we try to move it forward in the patient community. At the same time, these advances are happening in the provider and community and industry as well.
Thank you. And then I think there was a question, Dr. Jones, you had a question for Dr. Katona that I think would be worthwhile asking.
Yeah, it was a great talk. Thanks so much, Bryson. So, and it's great information for clinicians, know that with regards to adenoma surveillance in the younger people, that we sort of follow those existing guidelines. But I did have a question. If you find someone with advanced adenoma, in their 20s or 30s, not incidental ones or anything like that, or, maybe a polyposis, but they don't meet 10, are there issues that we should be reconsidering genetic testing for, short of colorectal cancer under age 50? And what are your guidelines? Again, I would be tempted in a 28-year-old who I found an 18 millimeter adenoma in. I would be very tempted to dive into that testing. So if you could help us out with what you've learned and how we should approach that issue.
Yeah, I think that's a great question. And, you bring up this threshold of 10 adenomas. And I think, in general, our threshold for testing people has dropped dramatically. And so now, people with 10 or more adenomas at any stage of life, we're offering genetic testing for. But yeah, these young individuals, I think that's an area where it's still kind of a data desert. And we just really don't know. I think young individuals that have advanced adenomas, 1 or 2, I mean, we are testing them, and they're getting sent to us because I think people are just, are rightly so, are just concerned and worried. But at least in my anecdotal experience, I find that our positivity rate is exceedingly low, and I Sophia, I don't know if
Yeah.
you all had a similar experience.
It's the same thing with us, yeah, that we do test them because they're so young, and you want to rule out that it's not a genetic susceptibility syndrome, but at the same time, the pickup rate is very low, yeah.
Yeah, so I think that, if it's one or two incidental small little adenomas, I don't push those patients to get testing, and I think the data doesn't really necessarily support testing those. For the one advanced adenoma, I usually will offer them testing, although with the caveat that it's almost certainly going to be normal. But I think we do need better markers to help better risk stratify that group. But then also, of course, genetic testing is getting so much easier to do that it's certainly very easy to do it to a broader group of individuals.
So this is sort of for everyone. A question from one of the attendees: what kind of studies are going on to uncover other hereditary factors associated with colorectal cancer? And what can patients and families do to stay abreast of new research findings? Maybe the first question to the physicians, and the second question to Robin, because I think you play a pivotal part in that.
Well, I mean, I think physicians are really in a tough situation in terms of, keeping up to date. I mean, I think that's really the challenge of the future. We are going to have amazing amounts of information, data, and technology coming out with these MCEDs, with somatic testing, again, down in the oncology space. I think clinicians are going to be really challenged, and I think it's going to be part of the evolution of the fourth wave of medicine, which is going to be really integrating with AI and integrating with tools that facilitate rather than complicate patient care. And there's got to be connectivity between real world evidence, these tests, which are becoming, I mean, just think about it. A person who goes in to see a doctor who gets a CBC and a PT-PTT and a Chem18, they could have had a genetic profile. One of my questions is when, and this will go back after we sort of run this, the Mayo data just suggested that colorectal cancers, 15% of them, when you test every person of all ages, have inherited genomic mutations, some high, some low. And I think lots of those pathogenic variants, because I think they had VUSs of upwards of 60% versus our normal, which is about 30%. I bet you we're going to get tons of reclassifications when we start broadly testing tumors to inform the clinical variants database. I just sat next to someone whose father had Lynch and a POLD2 mutation, yet she got colorectal cancer in her late 20s, and she had inherited that POLD2 mutation that was a VUS. That's going to go back and try to inform. So I think connecting this data is our greatest challenge. It's logistics and it's informatics. That's really where the move is going to be, as well as accepting that this is going to become part of the frontline medicine, not embedded in the oncology space.
I would agree. I think it's all about tumor sequencing, and I think there are a lot of centers that are able to sequence a lot of their solid tumors, and that's great. But then there are also centers that might not sequence all of their tumors, but should be doing things like immunohistochemistry on all colon and uterine tumors, right? That's, I think, generally accepted now as standard of care. But unfortunately, at least I know from uterine cancer, many centers still don't do routine immunohistochemistry, and that means that you're going to miss the potentially 15 to 20% of patients who have a defect in that, and the 3% of people who have a Lynch syndrome with uterine cancer. So I think just applying sort of standard of care management and screening of tumors is going to be critical.
And I think the other point that I'll just point out is that the number of hereditary syndromes we're identifying today is much higher than it was 10 years ago. And so for individuals who have concerning personal histories or from concerning families, I think it's also important that those individuals follow with a GI cancer registry, as I think that longitudinal follow-up and being able to be contacted as new developments or new advances come up is really important to keeping those families under careful surveillance.
I think that's a really, really good point, because as our genetic testing advances, more and more genes, or just the sequencing technologies, detection of large copy number changes improves. I think we will be able to pick up more genetic alterations in families. Robin, did you want to talk about how families can keep abreast of all the new research findings?
Yeah, I mean, I think that was, they covered a lot of what, we normally talk about. And I think that, VUS is being reclassified is an important piece of it. There are people that have been tested years ago, and the panels were much smaller as well. So if people have early onset cancers in their family and they had negative genetic tests 10 years ago, 5 years ago even, they may need to revisit what genes were on those panel tests, because they're continuously being expanded. VUSs are being reclassified, and patients are supposed to be notified from the testing companies about whether their VUSs are reclassified. I don't know if that's happening on a large scale or not, but we have a clinical trials search tool on our website as a resource for patients, but that is looking at clinical trials primarily rather than up-to-date research studies. And we kind of use our work with all of the professionals, like everyone else here on stage, to help us inform the patient community about up-to-date findings and stuff. And as an organization, we are always putting out on our own social media updates on research and new findings, especially around the different medical conferences and things like that, to make sure our patient community is aware of what's happening in the professional community. So
I was just going to briefly mention that the Collaborative Group of the Americas, which Sophia and I are both, and Whitney too, are both members of, are all members of, they have a good registry resource if you're interested in finding a hereditary GI cancer registry. I just posted the link in the chat there, but they go through and have them by location, so it's very easy to find a registry close to your area.
And I do think with all the social media, I do think there are opportunities for better informing patients about what kind of educational workshops are going on, and in relaying this information to patients really across not just the United States, but even across the world. It's much easier to disseminate this information than it was even 10, 15 years ago.
I just want to make one more comment. There's going to be a workforce issue that we're all going to have to deal with. Genetic counselors are supposedly distributed at 1 per 100,000 people, and we're going to be understaffed until 2030. Workforce suggestions, I would argue they're underestimating the need for genetic counselors by half, right? I think for anybody out there who's looking for a great field to get into, that's going to be the one, because genomic, any of the clinicians here don't think that in 10 years, every person with a solid tumor will get their genome as well as somatic testing? Does anybody think we won't be doing that in a decade? Sophia?
No, I think that's a great point. But in addition to genetic counseling, also bioinformaticians to interpret this data, right?
Yeah, we're going to need a molecular Sherpa to help us through the future. And that's really going to be genetic counselors who, again, I think we have to unembed from oncology and bring them closer to the front line, particularly in that preventive space. So I think that's a big issue. We talked about national policy a little earlier. I think that's a really important policy that those who are not in the genetics business need to weigh in on.
Absolutely. Absolutely. So I think I am being told that we're supposed to wrap up at 3. So with 2 minutes to spare, I just want to thank all of our speakers, not just in this terrific session 3, but also in the prior session. It's been really a wonderful day. And we look forward to seeing everyone tomorrow. I believe, at 10 a.m. Eastern time, and we'll regroup for session 4, which should also be a really interesting case presentation that I think will be very interactive. And thank you, everyone, for joining, for speaking, and for posing your questions. It really makes it an interactive session, which we always want and enjoy. So thank you, and have a wonderful Saturday afternoon.
Thanks so much.
Thank
Bye-bye.
you.